What do you fear the most in your life? It's actually one psychologist did a survey amongst thousands of people and asking the same question. What is your most inner fear? What are you most afraid of in your life? And what do you think the answer was? I mean, maybe we should ask the same question to ourselves. And the answer was uncertainty. People are most afraid of not knowing what's going to happen in the future. Even today, what's going to happen? What's going to be dinner tonight? That might be a surprise. But people are most fearful about unknown future. And I think that's one of the reasons why there's so many speculations and also the fear about death itself, because we really don't know. Nobody knows what's going to happen when death happens. If you think about that way, there are also some medical conditions that occur unexpectedly. And hopefully that all the medical conditions are somehow in degree unexpected. But if you think about patients with a seizure disorder or epilepsy, yeah, these are the patients who might do okay, just fine throughout the day, other days, except when they have a seizure. The problem here is we don't know what that's going to happen, when the seizure is going to happen. So I always think that our patients with epilepsy are the most courageous people, live through this uncertainty they have to face each and every day. So we're going to talk about a little bit more about that uncertainty. One of the way, what do we do when we do not know what's going to happen in the future or uncertain about the future? Sure, we have a religion for that. Yeah, the other thing is we have insurance. So we want to put some kind of dampening ways or the plan. If some unexpected thing happen, we like to mitigate that problem. Therefore, we prepare with some plans. Now, let me ask you, do you have any specific plan when the unexpected, the seizure occur out of blue, without any warnings? If seizure occur, what is the plan? Better yet, today's title, about the breakthrough seizures, meaning you're doing just fine. Let's say the seizures are well controlled for many years, and all of a sudden you have a seizure. Maybe you have one seizure, but maybe you have multiple seizures in that same day. And what is the plan? And that's the topic we're going to talk about today. Well, these are the things that people usually tell me, or maybe you were told to do one of these things. Call 911 when that happens, a seizure happens. Call doctor's office. Oftentimes you can't get hold of doctor. They're treating your family members or the patient, or they'll call family members for help. Well, sometimes you take extra medications you're already taking, hoping that they will reduce the recurrence of the seizure, or hopefully they will stop the ongoing activities. There's a limitation of what you can do with the existing medication. If you're taking A medication or the B medications, it takes a lot of time for that medications being digested and back into the system and go to the brain. So it may not be very helpful in that acute situation. Now the last one is to take a rescue medication. And unfortunately, I cannot see it tonight, but I want to ask you the same question. Do you have a rescue medication, or do you have a plan as a part of, and part of that is having specific rescue medication when that happens? We have many medications. You probably talked about this yesterday. There are so many new medications came out. Not only the 30s, 50s, but also more recently, 2000 and 2010, we have a whole bunch of medication came out. However, what are we missing here? We have so many medications. So obviously, it's a good news. We have a choice of medication and provide a medication that patients can tolerate better, and maybe, hopefully, it works better for them as well too. But at the bottom line here is what is the rescue medication, and how many rescue medications do we have currently available? Or do you know even any rescue medications that you talked about with your physician. What do you mean by the breakthrough seizures? Some people may, I just want to organize a verbiage here because people may use different words. Or if you look up the internet and looking for this kind of breakthrough seizures or cluster seizures, you may also encounter with different terms. Some people may use as a recurrent seizures, flurry of seizures, serial seizures, and all that. It is actually very common for people to have cluster seizures or seizure clusters. How I define it, the cluster seizures? Well, if you look at the literature, it's not that clear either, but seizure clusters can be defined clinically having more than 3 seizures in 24-hour period. Seizures does not have to be the big ones, even the small ones that happens 3 times a day. Yeah, it can be called clusters. Some of you may say that hey, I have a lot more than 3 seizures per day, especially certain syndrome like the Lennox-Gastaut syndrome patients may have multiple seizures per day. So the 3 seizures per day, maybe not even rare things for them. How we should define as a seizure clusters or breakthrough seizures is basically more than usual seizure frequency. For example, the patient has 1 seizure every 2 months. Now, the same person has 2 seizures in 1 week. I think there's something's going on and something we may have to address about why the seizures are occurring more frequently, a lot more than the established or expected seizure frequency. The problem here is not how we're gonna define the seizure clusters and how we're gonna even look for the literature in the internet, but more about what is available and what do we understand about these medications. Obviously, some people ask me, I'm going out of town. I'm gonna go to the woody area, I'm gonna camping. Is there something I can take with me to make sure that if something happens, then nobody will panic and some kind of plans? About a lot of people asking about flying, not anymore, but they used to, but I gotta go to East Coast flying out. Can I fly? Starting with that, or something should take before and after? What are the precautions? What are the things that I should watch out for? All of those kind of things. I have to say, until recently, we didn't really have a good medication to provide. And it's almost like, yes, some of the things you already did, yes, we can't really do much. Maybe you can take a little bit more of a clonazepam orally. Maybe you can just take extra medications you're taking already, but we don't know whether it's gonna even happen. So taking extra medication in anticipation that things may happen is not a good idea because it can increase the side effects. And I don't want you to go to a vacation and taking more medication and unable to enjoy the vacation because of the side effects. What are the consequences of seizure clusters? So you can imagine if somebody have seizures back to back. It doesn't even have to be back to back, clusters. 1 seizure and then about to recover, having another one. Well, physical injury is probably the most worrisome things. The other one is the third one here is status epilepticus. That means status epilepticus means the seizures occur continuously without stopping, by definition, more than 5 minutes continuously. And sometimes it's very difficult to control. Even when patients brought into the hospital, status may not stop. I actually have a patient right now in the hospital at the Banner University Medical Center that we did almost everything we know of, and the seizure is not stopping. So there are people who brought into the hospital, and if you look at how that happened, well, that's a very difficult question, but if you look at what happened, they often say that I have a seizures 1 and then 5 minutes later, another one, and they keep going, and eventually the seizure is never stopping and continues. So it is an opportunity when this seizure cluster first happened that we can do something so we can prevent not only the bodily injuries, but also more dangerous type of continuous seizures emerging from the seizure clusters. The fourth one, the neurological damage, let's say the brain damage, is controversial. It's intuitive to think that if you have multiple seizures, it's not going to be good for the brain. We all know that. And there's some animal studies showing that more and more seizures is not going to be good for not only the brain development, but also it can damage the brain, manifest as a difficulty with concentration, memory, or other executive function. Yeah, and then the mortality is the last one in the here, and said there's a increased risk, let's say about 3 to 4 times higher risk to end up in death if seizure cluster happen without stopping. I think this is a very telling story. This is based on the survey and the Pepanovich published back in 2017. And what she did was, they want to understand about this seizure emergency action plans on patient side. What do they understand? What they think they should do? And the clinician side. Overall, if you look at the left side is the circle. Overall, we know that about 70% people do not have an adequate seizure emergency plan. And we want it to be 0, but right now, I think it's close to 70%. Even if I give you this lecture, if you talk to my patients, they would say, well, I'm not sure if I have a plan. So the reason for that is we're not necessarily communicating in the sync. The patient may understand somewhat differently than what clinicians think they have or not. It's well illustrated the right side. If you look at the diagram here, the red line is patient's response, and the black line is the gray black is the clinician, doctor's response. So let's look at the very first one, and that's the most important one. The question was, do you have a rescue medication when this seizure emergency happened? Patient said, yeah, 20%. Okay, but doctors say 70%. Think about that. So you may think, oh, I don't know, I don't have a rescue medication, but your doctor may say, yeah, my patient has a rescue plan medication. So that's a little bit of a discrepancy, and that's one of the important things that we have to correct. So how are we gonna do that? We have to be in line with the plan, and we have to discuss specifically about what is the emergency action plan and what is the rescue medication for me and for your patients and loved ones. And that has to be clearly communicated, and how to use them, by the way, clearly can communicate between clinicians, doctors, and the patient and their family. So let's talk about what do we have as a rescue plan, rescue medication. Back in 1997, the medication called Diastat, which is a rectal diazepam, became available. And more recently, I'll talk about things a little bit more in detail, one by one. More recently, the medication called Nasalem, I actually misspelled it, it's N-A-Y-Z-I, a Y is missing here. Nasalem was just approved end of last year. And most recently this year, Valtoco was approved for this rescue medication for the seizure clusters. So you think about it, we have 30-some medications available in epilepsy world for the specifically designed to rescue people from these seizure clusters or breakthrough seizures. We only have 3, and 2 of them just came out. And I bet you not many people actually heard of Nasalem or Valtoco. They may be familiar with the rectal diazepam because since it's been around for so long, and especially the pediatric population, it's been actually used quite widely before. So let's start with the rectal diazepam or Diastat. Acutidyl is another name for it. Basically, it comes with a syringe. It can come with a different dosage, and Acutidyl, you can actually change the dosing of it, and supposedly one-time use. As the name indicates, the medication is inserted in the rectum, you know where that is, and then squirt the medication into it. Well, that's socially a little bit embarrassing if you have to do that in the airplane per se, or sometimes it's very difficult to get to that space. Let me just say it that way. Because you just have to take the pants out when the person is seizing. That is a daunting task. It's not easy to unload them and then give the medication. And you have to, like, if somebody's already shaking it, then obviously the target is also a problem. So even though the patients, if patient is a pediatric or baby, then the parents are very comfortable giving this medication. But if patients are adult, and if you kind of ask the patient, do you want somebody to give this medication to your you know where? They usually say, no, I don't want it. I don't want people do that to me. So that's the usual answer. And even when we are actually trying to encourage people to use it, not many people in adult population, especially, not many people want to use it for that, the social embarrassment reasons. And also, as I mentioned, it does take time to get there. So even though it's not something you can just give it right away and hoping the medication will kick in very fast. All this medication, all three medications that I'm going to be talking about today is a medication called class of benzodiazepam. So a lot of PAM you will see, benzodiazepam, diazepam, lorazepam, midazolam, all these are the class of benzodiazepam. So why do we give benzodiazepam? Well, for obvious reasons. Number one, it has to work quickly. So in order to work, this kind of medication work quickly, not only you can give easily, but also has to be absorbed quickly into the body and then get into the brain and penetrate into the brain fast. There are medications you can give quickly, but if it does not penetrate in the brain where the action needs to be, then that medication may not be very valuable. So class of benzodiazepine is known to, number one, you can actually give it in IV if somebody presents to the emergency department or the hospital with ongoing seizures. Benzodiazepine is the first class of medication they're going to get. So it's well established, safety is well established, and it actually works quite quickly in the brain. They all commonly have side effect of drowsiness and kind of if you give too much, there's some difficulty of breathing. So it's a sedating medication in a way. So the benzodiazepine, the diazepam has been available for more than 13 years now. There's some reluctance about the utilizing of this medication in adult population. Like I said before, in pediatric population, it's been used widely. The next medication, this is a medication got approved last year, 2019. So Nasalem, is correctly spelled here. Nasalem now is the same thing. It's a benzodiazepine called midazolam. It's the same kind of class. Midazolam actually is a shorter acting than other medications. So in a way, it gets into the brain quickly, but then it disappears from the brain quickly. There's a pros and cons about it. One good thing about it is it doesn't linger around too long. So when the patient recovers and seizure stops, functionally, they can actually recover quicker without being sleepy all day or next day. The minus side of that is people may wonder, would that be enough then, covering or preventing having recurrent seizures next several hours? The good news is actually they did a testing for 24 hours and see if seizures going to recur again or not. But again, the good news is over the 24-hour period is much better than not giving this medication in terms of preventing the next seizures. As you can see, apparatus is very simple. You don't give two, just give one, but it comes as 2-pack. It is a single dose nasal spray, meaning each one is 5 milligrams, and there's nothing other than 5 milligrams. There's no 10 milligram spray or 2.5 milligram. It's a single dose 5 milligram spray. So how do you give this? Basically, you choose one nostril, it's the left or right, doesn't matter. And then you squirt everything in the nose. And then the mucosal layer in the nose will absorb the medication and quickly get into the bloodstream and therefore into the brain as well. So the patient do not have to inhale. It could be used in the unconscious patients because again, they don't have to do any effort. Patient themselves can give it, but it's recommended given by the bystander or family member, somebody else can give to them. If patients are aware enough, they can certainly do that themselves as well. The other thing is you don't have to, even though apparatus looks like a prolonged tip there, you don't have to shove it in all the way in. That's not intended to do that. But again, you have to just put securely inside the nose and spray. Therefore, it may not be slip out or you may not lose the medication if you kind of spray right at the opening of it. Okay, so again, you don't have to put all the way in, whole length of the tip. So it's actually quite convenient. I've used quite a bit on this, and patients then report, good seizure control or preventing the next seizures after using it. It is designed again, giving one dose, but if the one dose is not working within like 5 minutes or a certain period of time, you can also, in 30 minutes, you can also use another one. That's why giving it 2 packs, but it's a single 5 milligram dose is most of the times needed. The next one is nasal diazepam. Again, it's a nasal spray. Looks just like the other one in terms of spray itself, looks very similar. And this medication is called Valtoco. The great news about this is it's a diazepam. So I mentioned before, there's a rectal diazepam called Diastat. The pediatrician has been used. So this medication has been already, the compound diazepam is widely used for seizure clusters already. So this one is really the same medication, but giving a different route. Rather than rectally given, this one is the nasal spray. This medication has to be the body weight based. So it does come with, I believe it's like 3 different dosing, and depends on the body weight. Your clinician, your doctor has to prescribe exact milligram dose. Sometimes you can just give a 1 squeeze and 1 spray. If you have a large body weight, then sometimes you have to give 2 of them. So if you have to give 2, recommend to give 1 to the left and 1 to the right. And so in most of adult population I've seen requires 2 sprays apparatus. So again, it really depends on the body weight, but it works very similarly. The company actually developed this compound, get quickly absorbed and was completely absorbed in the nose. And again, there's a very well-established compound in treating those acute repetitive seizures or seizure clusters. Is there anything else can we think of? Well, the other way we can give the medication quickly and expecting that's going to be absorbed into the body system very quickly is the intrabuccally. So it's a buccal diazepam film. So it's a familiar diazepam compound, but it's not a nasal spray. It's not the parenteral delivery gel, but this one comes like a strip, as if you may seem like Listerine strip type of things. The company is actually well known developing those kind of film-based medication. So you just stick it into the inside the mouth and then dissolve there and quickly absorb into the system very quickly. This medication has been under review by FDA, but had not been approved. And some people actually like to have the film, very small film. So some people I know that anticipating this medication could do very well, especially when person is traveling or fit into the purse. And by all means, the other nasal spray ones can fit into the nurse as well too. The other one is inhaled alprazolam. Alprazolam is the compound name for well-known medication with Xanax. The Xanax is also benzodiazepine. It's a part of benzodiazepine. So alprazolam is not readily used for seizure disorder. We haven't really used it a whole lot, even in acute situation or inpatient hospitalization. We tend to use diazepam very frequently. Other times we do use some midazolam, the nasolam is based on, but alprazolam, we don't use it very frequently, but this is inhaled. So if you inhale this medication, this is through the mouth, if you inhale this medication, the compound medication is absorbed through the lungs, into the capillary system and very quickly into the brain as well too. So this medication is still under the investigation, has not been approved in any country yet, the inhaled version of Xanax or alprazolam. So this could be a quite interesting medication. It does actually work very quickly. Absorption in terms of which one get absorbed into the system faster, inhaled version of it, followed by probably the nasal spray and intrabuccal. So those kind of difference is all of a sudden we gonna have a lot of choices about how we gonna be delivering the rescue medication. But I just want to emphasize all this medication is class of benzodiazepine, and therefore they're gonna be causing certain duration of sedation. So this is not the medication you do it and then, for example, operating heavy machinery or driving a car. You're not supposed to drive a car anyways, but yeah, those kind of things you should avoid. And just once the medication is given, they need to relax and ready to even fall asleep, sleep at times. This is a kind of a trying to answer, do we know who's gonna more likely develop cluster seizures than others? And this is based on the literature search. And we actually trying to publish this data. It's been under review, but we actually looked through all the publications regarding and try to figure out the risk factors. Because if only 20% people think they have a rescue plan and 70% physicians, we need to know that who needs to have a conversation with their doctors more likely. So people who had a higher risk developing of seizure clusters, they must have this discussion with the doctors. So what are the risk factors here? Number one is seizure frequency. If you already have high seizure frequency, very frequent seizures, the chance they're gonna have a cluster them together is high. Patient who had a prolonged, I mentioned about the status epilepticus, the history of a prolonged seizures in the past, and somebody who actually had a seizure cluster before, these are the ones who's gonna be having more likely develop these cluster seizures. People who are taking 2 or more seizure medications, obviously do that because their seizures are not well controlled. So it's kind of tied to the high seizure frequency category, but those people may be. The other kind of minor risk factors are the lighter green color. It's like people who had a head trauma, for example. People who had a brain infection, CNS infection, or it's a symptomatic generalized epilepsy. That's kind of older term, but people who have, for example, Dravet syndrome or the Lennox-Gastaut syndrome, those are the category of people who may develop seizure clusters more likely than others. Other possible risk is a young age. This is actually quite important. So the people, not only we're not talking about pediatric population, we're talking about teenage and also people in their 30s, 20s and 30s. Some unknown reasons, they are more likely to develop cluster seizures than older population. Now this one shows, this is actually an important slide to illustrate that if you have a one seizure, what it shows is that if you have one seizure, how long does it take for those people who have cluster seizures? How soon after they're gonna have a second seizure? Well, the average is about 131 minutes. So you can imagine it's about 2 hours plus to have the second one after the first one. But if you have the second one, then how long do you have to wait for the third one? we're talking about an average, about 46 minutes, about the fourth one, 21 minutes. Here's, you got the point here. So the subsequent seizures are more likely to occur in a shorter interval. And as you can imagine, if you go all the way to the right, how about 6 seizures, 7 seizures, they'll be shorter and shorter. And then eventually they're gonna have continued seizures without even break in between. So what does that mean to you? So to me, it means this data kind of illustrate that even after the second seizure, even though the classic definition is 3 seizures in 24 hours, I'll be very worrisome not having any plan if somebody already have 2 seizures, because that the third seizure is gonna occur much sooner, not an hour later or 2 hours later, but within an hour. So this is a kind of window. It's actually good news as well in a way that if the seizures are occurring within few seconds interval, then we may not have enough time to intervene. So we have, in average, some people are like that too, but in average, people do have some, at least a half an hour from the second and third one. So that it will give us a time to act on it. Okay, so the other thing is, what if I have a 1 seizure, should I give the medication to prevent the second one? Well, that's based on the patient history. If the person has cluster seizures when they have seizures all the time, sure. But if they're only known to have a cluster seizures rarely, and most of the times they have only 1 seizure and recover from it, I would not necessarily give the rescue medication then and waiting for the second one. After the second one, I'll be most inclined to give the rescue medication to prevent the third one and hopefully even shorten the ongoing second seizure. So you don't have to wait with a nasal spray, especially, you don't have to wait until the seizure is over. You can actually give the medication while they're seizing and hope that the medication will act quickly to prevent the next one, as well as stopping the ongoing seizure activities. And that's what the clinical study has shown before. If you do that, not only seizures are better controlled down the line and next 24 hours, but sometimes you can actually shorten the duration of ongoing seizure activity. I think it's a portability in terms of what is the ultimate rescue medication, but preferred medications. Obviously, it has to work very quickly. It has to does not interfere with their daily function too much, or people then recover quickly from the medications given. But the convenience of it, not in terms of how easy to carry and store, but also how convenient it is to give the medication to the patient. I already mentioned that it is very convenient to give the nasal spray than other form of medications. And also, you may not use this medication very frequently, so we like to have a long shelf life. And the medication I share, whether it's Valtoco or Nasalem, they have about 1 year shelf life. So you can actually store that without worrying about this medication is gonna go bad. And the last one is, you want the medication that works for all different type of seizures, but not only very specific type of seizures. Good news is, the benzodiazepine as a class and all the medications I mentioned actually do work well for many different, just about any type of seizures, but as a rescue medication and often given as IV in the hospital. Now, you may wonder, if benzodiazepine working so well and we use it as a rescue medication, how come we don't use it every day? Why don't we just take that medication every day? Well, there are certain medications licensed to give every day as an everyday medication. For example, clobazam or the clobazam oral films. Those are already available given as even though it's a benzodiazepine. The main reason we don't do that is that this kind of a medication, generally speaking, this benzodiazepine, causes a lot of drowsiness, and sometimes people take it to go to sleep, as you know. But also, people may develop resistance to it. So usually about 3 to 6 months after taking medication daily, afterwards, not only you have to increase a higher dose, but even at the higher dosage, the medication may not even work. So patients develop a tolerance or resistance to the medication. So that's why these benzodiazepine class of medication is not given every day, unless it's I believe it's a clobazam. That medication is well established, not necessarily causing that kind of a resistance, even after giving many years. But diazepam or even midazolam, the medication I share with you, is known to cause that kind of resistance to it over time. So here's my message tonight. Let's have a plan together. The together is a key word here. So it's not enough for the doctors to know what to do. I think the patients and patients' family members should also know what to do, and has to be clearly communicated. So this is exactly what I'd like to encourage you tonight. If you had not had a discussion with your doctor, talk about it. I'm not asking specifically for the medications I mentioned, but maybe the person has different ideas. So explore what is available, what might be most suitable for your need, and also is really clear communication. I like to actually get a phone call from now and say, Dr. Chung, we did actually do ABC as we planned and we talked about. What's the next step? Rather than at the close seizures, what should I do? So let's just open that communication and let's have a plan together. All right, I'll just end here. I thank you very much again for your attention, and I'll be happy to address any questions today. Now.
So if you can type your questions into the chat box, or if you think of questions later, I can forward them on to Dr. Chung so that he can answer, and I'll send them back. But you can send them to az@efa.org if you think of questions later for Dr. Chung.
Oh, so there's a lot of things in the chat box. I don't know if I have a chance to read them all.
No, none of them are questions though.
Oh, so everybody's saying hello and hi.
Yeah. So, well, thank you very much, Dr. Chung. It was very enlightening.
All right, thank you again. And I, once again, strongly encourage you to have the communication with your doctor. Have a good night.
All right. So next we have Dr. Sue Herman, and she's going to talk about the epilepsy learning healthcare system. Dr. Herman, are you there? You want to put your video on?
I am here. Hang on one second.
There you are. Hi, Dr. Herman.
Hi, nice to see you.
So Dr. Herman is an epileptologist at Barrow Neurological Institute. She's the director of the epilepsy program at BNI. Dr. Herman is a national leader in EEG technology and interpretation, and she's currently the co-principal investigator of the epilepsy learning healthcare system. Therefore, that's what you'll be learning about from the expert tonight. Go ahead, Dr. Herman.
All right, thanks. Let me share my screen here. All right. So can everyone see my screen now? Susanna?
Yes, we can.
All right, perfect. So I'm going to talk about the epilepsy learning healthcare system, which we fondly call ELHS, which is a new network and a partnership between some academic epilepsy centers in the United States and the Epilepsy Foundation, many other organizations involved in the care of people with seizures, and also patients and family members of people with epilepsy, to try to create a new standard of care. These are my disclosures, meaning where I get grant support to do this research. None of them are really related to this presentation. So one of the things that we all recognize is that despite the fact that we have many new medications for the treatment of seizures, and this is just a timeline showing how many medicines have been developed for the treatment of seizures. Right around here is when I did my fellowship, when I did my training as an epilepsy specialist. And at that time, there were actually only 5 medications available for the treatment of seizures. And since then, we've had the introduction of many, many new medications, as well as devices and increase in epilepsy surgery. There are now almost 30 medicines that can be used to treat epilepsy. But despite this explosion of new treatments, still about 1/4 of people living with epilepsy don't have complete seizure control. And many of the people who do have seizure control do it at the expense of having side effects from their medications. We know that a lot of patients aren't referred for therapy early in the course of their epilepsy and suffer for many years without getting effective therapies, things like epilepsy surgery and epilepsy devices. And that many of the problems that go along with epilepsy, like problems with memory and thinking, problems with depression and anxiety, are often underdiagnosed or undertreated because they're not brought to the attention of physicians caring for people with epilepsy, or the physicians are not experts in treatment of those other medical problems. And then finally, unfortunately, seizures can have a risk for shortening life and can increase the risk for death from accidents and injuries and sudden unexpected death in epilepsy because of inadequate seizure control. And because of this, we really felt that there was a need to do more to try to bring new treatments to patients and to work in partnership with patients to identify the areas that will make the biggest difference in people's quality of life. So to do this, we created what's called a learning healthcare system. And this is a new type of network that is based in something called quality improvement. And what do I mean by that? What we do is we identify areas where there's a gap in treatment or a gap in care. We collect information from visits. Every time we see a patient, we collect information about how they're doing, what medications they're on, whether they have depression or anxiety or thinking problems. And then we look at that data across an individual epilepsy center and across all of the centers in the network to see where there are problems and where we need to do better. And then at each of the centers, we actually then develop ways to try to improve the process. And I can give you an example. One of the things that is sometimes a problem in epilepsy care is that patients have trouble taking their medications for a variety of reasons. Maybe they have trouble remembering medications because they have memory problems. Maybe they can't afford their medications. Maybe the medicines taste terrible and they don't want to take them. Or maybe they don't want to take the medications in front of other people. We developed a set of tools that allows us to have patients tell us when they're having trouble with medications, all of the different causes why they may have trouble with medicines. And then we can develop tools to give to the patient to help them get their medications more easily. So for example, if somebody has trouble remembering their medicines, then they might get education from a nurse on how to use a pill box and how to use a reminder system on their phone or an app in order to help them remember medications. Or if they're having trouble paying for their medications, we might provide information on patient assistance programs that can provide medications at low cost or for free. Or we can work with the insurance company in order to get the medications at lower cost. So the first step is to identify the problem, looking at it across all people with epilepsy, and then develop tools that can be used in each individual person with epilepsy in order to improve their own care. And this process is being done simultaneously across all of the different epilepsy centers. So as soon as we find something that works, rather than having to reinvent the wheel at center 1 and center 2 and center 3, as soon as center 1 finds something that's useful, we can actually pass it on to centers 2 and 3 and they can start using it right away. So what this does is it allows us to do more work at the same time and to come up with more rapid solutions to improve care. So this is basically what a learning healthcare system is. It's rapid improvement in care that is important to patients. One example of a learning healthcare system is this network called ICN, which stands for Improved Care Now. And this is a network that looked at patients who have pediatric children patients who have inflammatory bowel diseases, so problems of the digestive system. And when they first started looking at this, only about half of the patients were in remission, meaning that they had good control of their inflammatory bowel disease. And then over the next 10 years, they were able to increase the rate of remission, the rate of good control of their disorder to 80%. So from 50% to 80% over this 10-year period. And what's really striking is that there were no new medications that came out for the treatment of this disease over that period of time. Not like the epilepsy world where there were 25 new drugs. They had no new treatments. So all of these improvements were from using the medications that they had in a better way, figuring out how to teach patients how to manage their disorder more easily, and improving communication between patients and physicians in order to get to this 80% range. And what we hope is that we can do the same thing in epilepsy. So we've created what's called the Epilepsy Learning Healthcare System. And this includes people with epilepsy as well as their families and caregivers. We call these volunteers PFPs, or patient family partners, healthcare providers, so the doctors, nurses, nurse practitioners, medical assistants, EEG technologists who are at each of the individual sites, community services organizations like the Epilepsy Foundation, the national office, as well as the Epilepsy Foundation of Arizona, and then a whole host of other organizations that support people with seizures, and researchers who are interested in finding ways to improve care and determine whether new treatments are effective. And all of these people are working together in order to improve care from every different direction. So nobody's sort of working on their own. Everyone is working in collaboration. Right now we have 13 epilepsy centers around the country. We have 23 different community organizations, including the Epilepsy Foundation of Arizona. We have 11 sponsors. These are companies that are providing financial support for us to build the network, and many, many patient and family partners who are volunteering to help us develop new care pathways. And this is just a map of where all of these different people are. Here we can see our groups in Arizona. We have a lot in California around Los Angeles, and then a few in the South and many in the sort of Northeast region. And what we try to do is partner the academic medical center like Barrow Neurologic Institute with a local epilepsy foundation office. And then we work in partnership with that office to deliver better care. So the vision for ELHS is for all people with epilepsy to live their highest quality of life, striving for freedom from seizures and side effects, and we won't stop until we get there. And this is really a really important point. So when we first started looking at what our vision should be, the people involved in developing ELHS thought that we should focus on making people seizure-free or reducing seizures. And the patients who were involved and their family members who were involved in ELHS basically said, nope, that's not good enough. If all you do is improve seizures and you don't improve quality of life, then you actually won't have helped us very much. And so epilepsy and the problems associated with epilepsy go far beyond seizures, and that we needed to look at all of the associated conditions to make sure that we were looking at the whole person, not just their seizures. So we actually changed our vision so that it was focused on quality of life rather than seizure freedom being the most important factor. The second part of how patients helped us with this is, and we won't stop until we get there. So we all know that unfortunately, we don't have a cure or a way to control seizures in every person who has seizures. But by having this continuous improvement idea, we promise that we won't stop working to make people seizure free. We won't stop working to improve quality of life. And eventually we will be able to get to this highest quality of life for everyone, even if we can't do it today. Our mission is to work hand in hand with patients and their families and their caregivers to improve quality of life, improve seizure control, and make as many people as possible seizure free. This is just a diagram of the epilepsy learning healthcare system. We have multiple people who are working in different areas that are important for the functioning of the system. This set of pictures down here at the bottom are all of the leaders of the epilepsy learning healthcare system, and they work in what we call cores, so areas that are focused on one aspect of the epilepsy learning healthcare system. So the first is the clinical core. This is the group that is working to improve care in the office visit, in interactions between patients and providers in their visits, and trying to improve outcomes around seizure control, prevention of seizure clusters, as you just heard about, improving depression and anxiety, improving seizure frequency. And then we have our quality improvement core, and this is the group of people who are telling us how to improve care, measuring whether the care is actually better. We have a whole team of people to do that. Then we have a group that's pulling together the data, the information that we collect about every clinic visit so that we can ensure that we're really doing the best that we can to improve care. We have a supportive services core, which helps people to understand how to do self-management, how to take care of their epilepsy in the best way possible, to provide education to patients about seizures, and to help patients get to the right providers at the right time. And then finally, we have the community engagement core, which pulls together all of the other groups who are helping to support patients with seizures, like the Epilepsy Foundation, some of the organizations for people with early life epilepsy, the Rare Epilepsy Network, and a whole host of other organizations that are trying to provide services for people with seizures. What this looks like from the provider point of view is that the core of ELHS has the organization. This is where we provide all of the structure to collect information about how people are doing in control of their seizures, control of their depression. And that information is then fed back to the site team. So at each site, we have doctors, other providers, people with epilepsy, people who have to do with data, information technology, and local quality improvement experts. And they get information from the ELHS core that tell them how their patients are doing as a whole, the whole population of patients seen in our clinic, and how individual patients are doing in terms of seizure control, depression, anxiety, etc. So information is always going back and forth between the main data collection and the individual site. The other important component of this is at each site, we have patients and families, our PFPs, who are involved in helping us determine what kind of improvement needs to be done and how our efforts are actually doing, whether we're actually improving care and making things better. I'm gonna skip this. We do this in something called a PDSA cycle, Plan, Do, Study, Act. So we basically look at a problem, we decide how we want to fix it, we do the steps necessary to try to fix it, and then we look at the data and try to figure out whether we've actually improved anything. So for the example that I gave before in terms of taking medications, we want to know how many patients actually fill out the survey that we give them about whether they're taking medications appropriately. Then we want to see whether the tools actually help people to do better in taking their medicines. And then finally, we want to know whether taking medications better results in improvement in seizure control. So all of those things are tested with a small group of patients until we're sure that our new tools are actually working to improve care. And here's an example, and this was in what we call seizure documentation, or writing down in a standardized way how many seizures patients are having every time they see the doctor. And when we first started doing this, only about half of the time were doctors writing down every seizure type and how often every seizure was happening for every patient. And by the end of our testing, we were actually at nearly 100% of the physicians and other providers writing down how many seizures patients are having at every single visit. And the reason that this is so important is that if we're not tracking how patients' seizures are doing and you know, how often they're happening and how severe the seizures are, then we don't actually really know how we can best change their medications to improve seizure control, whether people are candidates for other types of treatment. So a simple step like making sure that every single visit, the person's frequency of seizures is written down so we can study it, was easy to achieve using this new network. So we're looking at a few different things in ELHS. We're looking, as I said, at seizure frequency, both from the provider point of view, but also for the patient point of view. So how can we encourage patients to keep seizure diaries and logs? How can we support patients in understanding what the different types of seizures there are and what kinds of seizures a particular person has? Medication adherence, so whether people are taking their medications on a regular basis without missing doses. Quality of life, how people's overall health is doing. Mental health, anxiety and depression, and other problems with thinking. And then women and girls' health. Are people having regular menstrual periods? Are they, do they know what to do in order to prevent unwanted pregnancy? Do they know how seizures might affect pregnancy and the development of their baby? So do we have enough education about women's health? Next, we're going to be looking at getting patients more involved in the network, making sure that patients can transition, pediatric patients can transition from a pediatric epilepsy center to an adult epilepsy center. Make sure that patients get referred for specialized epilepsy care to an epilepsy center early in the course of their seizures. So not waiting 10 or 15 years with uncontrolled seizures before patients get referred to a site where they can get more advanced treatments and education. So what can patients do to improve care? So number one is, if you're being seen at a center that's involved in ELHS, or actually at any center, you want to sort of take charge of your own health. You want to write down how often your seizures are happening in a seizure log or a seizure calendar. Mark down when your seizures happen, what kind of seizures they are, and any possible triggers for the seizures. Because this information allows your physician to document the seizures in the medical record and look at them over time to see how you're doing when medications are changed, or when you're in a stressful situation. We can actually look at seizure frequency over time. The next is to take your medications on a regular basis. And even more importantly, let your doctor or other provider know if you're having trouble taking your medications, either because you are having trouble remembering them, or you don't like them, or you don't think they're working, or they're causing side effects, because we can't actually improve any of those issues if we don't know that they're happening. The next is to tell your doctor about any mood problems or problems with thinking, because there are some very good treatments for mood problems and some things that we can do to help with trouble with memory and concentration as well. And then most importantly, before you have your visit with your physician, think about what you want to talk about at the visit. It's very easy to go into the office and have your doctor, start asking you a whole bunch of questions. And by the end of the visit, you're like, I didn't get to ask what's most important to me. And so if you write that down and think about it before you even step into the doctor's office, then you can set the tone for what's most important for you. And these are the kinds of things that we're trying to encourage in the epilepsy learning healthcare system, to have patients be able to have a voice and be the person who's in charge of the epilepsy care and what's most important to you in your own life. The next thing is patient-family partners. So people can volunteer to be part of the ELHS network by becoming a patient-family partner. And this is really important because we need to know the things that are most important to patients in order to develop tools that are most useful. And so PFPs can actually participate in a lot of different ways in the ELHS network. So the first is that you can help us to figure out what kinds of new procedures we want to use in the clinic and test whether they're actually useful or not. So maybe you want to tell the site team, the team at the center, about problems at the site so that they know that there's an issue that they need to try to correct. You can suggest ways that the site team can provide better care. Maybe you think that you have an idea that can really help people with epilepsy to have a better experience in the clinic. We want to hear about that so that we can try to make those changes that will improve patient outcomes. And then finally, work with other patients to test some of the new things that we're doing. So for example, at Barra, we have a new self-management program called PACES, and some of our patient-family partners are participating in that process and actually helping to lead the program, teaching other patients about how to take better control of their seizures and improve their seizure frequency and quality of life. PFPs are also really important in making sure that the patient and the family perspective is heard, and that the physicians are really always designing things that are helpful for patients. And we've had a couple of aha moments where we thought we had developed something really good, and then when we showed it to patients, it was clear that it wasn't that helpful. So one of these was a set of educational materials that had been developed for people with new seizures. They had just been diagnosed with seizures or epilepsy, and the Epilepsy Foundation had put together a whole packet of information that providers thought would be helpful. And what patients said when they got that is, oh my goodness, this is so overwhelming. I'm so scared now. This is way too much information. Half of it I don't need. Half of it is really scary. And most of it is really confusing. And so we actually had to go back to the drawing board and say, all right, what's really essential for somebody with newly diagnosed seizures? What can we take out of this packet so it's not 100 pages long? How can we make it easier to understand? And how can we make sure that it's information that is helpful to people rather than being frightening? So that's just an example of how important it is to have the patient and family perspective. The other thing is to actually help us test new tools. So we are developing a new database where people will be able to answer questions before their clinic visit to tell us how they're doing. Questions about their mood, question about how many seizures they're having. And we wanted some patients to give us feedback about how that worked. So we sent out the information, patients logged in on the internet and filled out these questions. A couple of our patients came back to us and said, I don't really understand how to use this system. It's very confusing. I'm having trouble logging on. And that was really important information for us to know because we wanted all patients to be able to use the system. So again, we had to go back to the drawing board, make better instructions for patients on how to get to the system, change the wording for some of the questions so that it was less confusing, and really get something that was appropriate for all of the patients and families in the network. And then finally, PFPs can work with the local Epilepsy Foundation office staff to provide education, to provide other information to patients in the local community. So I think here I will stop. I don't know how much time I have left. I want to leave some time for questions invite you all.
I really like it.
I
know some other people do.
I want to give everybody time to give some feedback on what they think might be helpful for the epilepsy learning healthcare system, ideas about how we can get patients and families more involved in this process, because the more people we have working towards better outcomes for people with epilepsy, the more likely we are to succeed. So I will stop there.
So Dr. Herman, Carlos has a
Yes.
question. He asked, does ELHS publish the data it collects online? The data will be very powerful to see.
Yes, so eventually we will be publishing the data online, and we're just starting to collect the information in a standardized way in our registry, so expect to see some data soon. This is a network that is very, very new. I can actually show you, one thing that we did, which was very helpful. This is our telemedicine effort. And this is something that we had done at Barrow when COVID hit and everybody stopped coming to the office and we had to do all of our visits by telemedicine. We were really worried that patients wouldn't be able to get good access and that we might have a lot of trouble completing visits. And so we set up a project where we tracked the telemedicine clinic visits. So this was how we were doing before COVID, about 100 visits per week. When COVID hit, we went down to about almost half of that. Then, and we were doing most of the visits here by phone. We got a little bit better at doing phone visits. We got up to the same number that we were doing before COVID. And then we tried to go to video visits or Zoom visits. And we actually, again, were doing many fewer visits. It was much harder for patients to get onto a telemedicine video visit and have an effective visit with the physician. So our numbers went down again. But as we got better, and we had a lot of tools that we developed in ELHS to help both patients have a better idea what to do in a video visit, but also for our clinic staff to be able to do more efficient video visits. And you can see that over the next few weeks, we actually went up and we were doing about 50% more than the visits that we were doing before telemedicine, because it turns out that it's actually much easier to see people on video than to have them going in and out of clinic rooms and sitting around in the waiting room and having to come to the back office. That's all wasted time. And it's actually much more efficient to do things over video as long as everyone knows what to expect and how to do the visits most efficiently. So this is one example of the kind of data that we hope to be able to show from ELHS.
anyone have any more questions? So if you do have questions later, please let us know and at az@efa.org, and I will present them to Dr. Herman and she can answer them. And I will relay that back to you. There is a question I see from Julie for Dr. Chung, so that will go to him as well.
Yeah, and you know, we really want to hear from everyone about things that they think might improve epilepsy care. And you know, it doesn't have to be a final idea, just a suggestion. We're really good at testing new things and trying to figure out what will work. Suzanne can definitely attest to some new things that we're trying to do that we hadn't thought about doing before, and hopefully they will be successful.
Well, thank you very much, Dr. Herman. I think everyone learned a lot about ELHS. And thank you very much, everyone, for attending. And we have one more virtual conference, and that's going to be on Thursday. And those who've signed up will receive your link for that conference. So good night, and maybe I'll see you on Thursday. Bye-bye.
Good night, everyone.